Welcome to PGOG-Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is fertility sparing treatment modalities in obstetrics and gynecology. What is fertility sparing in obstetrics and gynecology? It is conserving uterus, fallopian tube, ovary for future fertility when there is a possible indication for their removal. That means patient is not interested in fertility preservation. As a obstetrician and gynecologist, we might take a decision to proceed with removal of either uterus, fallopian tube or ovary. Now this conservation is done by using alternative surgical or non-surgical interventions. It also includes cryopreservation of ovum, embryo, ovarian tissue in case removal of gonads or ovary is unavoidable. The principle of this fertility sparing treatment modalities is balancing disease control with fertility preservation. It includes, as I said already, it includes surgical as well as non-surgical interventions. It also includes benign as well as malignant pathologies requiring removal of reproductive organs, though malignant indications are discussed more in literature. Now remember that it is not fertility enhancing surgery. Fertility enhancing surgery is the surgery which mainly includes surgical manipulations as a treatment for infertility. Surgical management of infertility. Now, there are obstetric conditions with an indication for the removal of uterus, tube or ovary, which are included under the topic of fertility sparing procedures in obstetrics. If we see peripartum obstetric hysterectomy, the terminology includes two entities, Caesarean hysterectomy and postpartum hysterectomy. Indications of obstetric hysterectomy where fertility sparing procedures play a role. First is atonic PPH not responding to medical management, where we can proceed with balloon tamponade, compression sutures, vessel ligations such as stepwise devascularization and uterine artery embolization. Viewers can see the video on surgical management of PPH for further details. Whenever in a vesicular mole we do evacuation, sometimes there is torrential bleeding, and for that uterine packing and again uterine artery embolization are the modalities to prevent proceeding with hysterectomy. Now whenever PROLAC is being trial of labor after cesarean, and if there is a scar rupture, then suturing of the rupture site prevents hysterectomy procedure. Then hysteroscopic evacuation for retained products of conceptions is recommended because sharp curettage can lead to intrauterine adhesion, formation or Asherman syndrome. Similarly, vacuum curettage is preferred over the sharp curettage for all types of abortions. So suction and evacuation is better than going with a dilatation and evacuation with a sharp curette. In placental abruption, prompt blood component administration, aggressive treatment of atonia, and aggressive treatment of hemorrhagic shock prevents hysterectomy. In placenta previa, hysterectomy rate is 2% when there is no placenta accreta spectrum. Now, PAS is placenta accreta spectrum, which includes placenta accreta, increta, and percreta. So if it is placenta previa is not associated with this, still hysterectomy rate is 2%, And to prevent hysterectomy, the other measures which can be used in a case of placenta previa are use of Foley's balloon or Bakri balloon, compression sutures such as Cho sutures, stepwise devascularization, internal iliac artery ligation, and uterine artery embolization. Now, these next two entities, that is Caesarean scar pregnancy and cervical pregnancy, are the major obstetric entities where these interventions play a very important role in prevention of need to proceed with hysterectomy. So first, let us see about Caesarean scar pregnancy. There is a rising incidence of this with increasing Caesarean sections being performed all over the world. It has two variants. One is an endogenic, where it grows towards the uterine cavity, and it has a variable obstetric outcome if it is continued. Other is exogenic, which grows towards bladder or abdominal cavity. Here, if continued, if pregnancy is continued, usually it leads to placenta accreta spectrum, which needs hysterectomy. It is also said that PAS is it occurs as a result of this Caesarean scar pregnancy, or in other words, Caesarean scar pregnancy precedes PAS in many cases. So if we diagnose Caesarean scar pregnancy early, then termination is recommended to avoid hysterectomy, because if it is continued, there is a risk of uterine rupture, there is a risk of PAS requiring hysterectomy. Various ways to avoid hysterectomy are either we can proceed with laparoscopic ischemic resection, vaginal ischemic resection, where as we do for vaginal hysterectomy, anterior colpotomy is done, and then the resection of this scar pregnancy is done by ischemic resection, or UAE followed by dilatation and evacuation with or without hysteroscopy. Or one can do hysteroscopic resection or USG guided vacuum aspiration. So these are the various ways by which this Caesarean scar pregnancy can be dealt with to avoid need to proceed with hysterectomy. Medical method is also used to treat this Caesarean scar pregnancy, and I have myself used methotrexate 1 milligram per kg body weight, which is given systematically as well as locally. With that, we can use Foley's balloon catheter to arrest the bleeding, which is very effective. Or there is a mention of a novel or a new double balloon catheter, which can be used with methotrexate, where upper balloon is larger, which mainly stays in the uterine cavity, and lower balloon is compressing over this Caesarean scar pregnancy when methotrexate is being given to avoid excessive bleeding during methotrexate treatment. So this is double balloon catheter. So this can be used, or a simple Foley's catheter also can be used along with methotrexate, which leads to gradual resorption of this Caesarean scar pregnancy. Early termination prevents hysterectomy, and future successful pregnancies are possible, which are uh, presented as case reports or case series in the literature. Next is cervical pregnancy. Though rare, it also sometimes bleeds profusely if remains undetected, and one might have to proceed again with the hysterectomy if it is remains undiagnosed for a long time. So for cervical pregnancy, methotrexate is the first line of treatment. Success is more if gestational age is less than 9 weeks, CRL less than 10 millimeter, absent fetal heart rate with beta HCG less than 10,000 milli international units per ml. Methotrexate can be given as systemic or local injection. Now here there is one interesting treatment modality which is called as chemoembolization. What is done in chemoembolization is first methotrexate is injected in the uterine artery while doing uterine artery embolization, and then embolization is done. So combination of this methotrexate with UAE is called as chemoembolization, which is also used successfully in these cases of cervical pregnancy. Suction evacuation can be tried with preoperative UAE, uterine artery embolization, or with intracervical vasopressin injection, or with cervical circlage at the level of internal os to compress the feeding vessels, or we can do first take hemostatic cervical sutures at 3 and 9 o'clock position and then proceed with suction evacuation. So these are the various ways, but remember for cervical pregnancy, first choice of treatment, modality of treatment is methotrexate, which can be combined with KCL if fetal heart is present, and it can be combined with UAE also. Now, whenever there is a tubal ectopic pregnancy, fertility sparing surgery or modality is mainly to avoid salpingectomy. If it is unruptured tubal ectopic, then only we can go ahead with that. For ruptured tubal ectopic, there is no other way but proceed with salpingectomy. Here, methotrexate plays an important role, and again, viewers can go through the video on management of unruptured tubal ectopic pregnancy, which is available at PGOG. Salpingostomy is another surgical option where the incision is given over the site of ectopic, and aspiration or removal of the products of conception is done, and the wound is kept or incision is kept open. That is salpingostomy. Now, if there is a tubal interstitial pregnancy, it is another high risk where there is a very high risk of proceeding with either salpingectomy or hysterectomy, where methotrexate plays important role, or one can proceed with corneal resection or corneostomy with vasopressin injection in the myometrium. Now, for these pregnancies, chemoembolization again has been given in the literature as successful way of managing interstitial pregnancies by injecting methotrexate in uterine artery and then followed by that by uterine artery embolization. So combination of methotrexate with UAE, chemoembolization. So till now we have seen that in obstetrics, whenever fertility preserving or fertility potential needs to be preserved, fertility saving or fertility preserving modalities are to be seen, UAE plays an important role, uterine artery embolization. Case reports indicate successful pregnancies after UAE, and according to Williams Obstetrics, fertility is not affected by this procedure. Indications of UAE in obstetrics are whenever there is a PPH, especially secondary PPH, where usually patient is hemodynamically stable, because we need the patient to be hemodynamically stable to be able to shift the patient from our obstetric unit to the facility where UAE can be performed. So hemodynamic stability is important prerequisite to proceed with UAE. In non-tubal ectopic pregnancies such as cervical pregnancy, scar pregnancy, interstitial pregnancy or abdominal pregnancy, uterine artery embolization plays an important role. In placenta accreta spectrum also, it has been given in the literature that it plays important role, but uterine conservation for PAS is at experimental stage only. In practice, in almost all cases of PAS, hysterectomy is necessary, and especially if it is a placenta increta or percreta, one should never try to go for conservative management. Conservative is where you leave the placenta and just wait for the autolysis and absorption, which has a very high risk of infection, and that is why it is given that it is only under research or experimental stage only. Hysterectomy is the standard practice. Methotrexate doesn't play any role in the prevention for need for hysterectomy in this placenta accreta spectrum, unfortunately. Now, vesicular mole, if there is severe bleeding, then also we can proceed with UAE. Now, as you can see, through the femoral artery, catheter is passed, which passes through external iliac, common iliac, opposite-sided common iliac, opposite-sided internal iliac, and then to the uterine artery. That is how catheter is passed. In very high risk cases, sometimes catheter is uh, passed beforehand, and then whatever treatment modality needs to be given is initiated, especially for PAs. Chemoembolization, as we have already seen, it is first injecting methotrexate through this uterine artery and then proceeding with embolization. Now, there are certain situations in obstetrics where obstetric hysterectomy cannot be prevented. There is very limited or almost no role of fertility sparing procedures, such as in very septic abortion with severe infection, puerperal sepsis, which is neglected case with severe infection. Placenta accreta syndrome, we have already seen Caesarean hysterectomy is needed. Leaving placenta for self-absorption is experimental because of serious complications, and there is no role of methotrexate. And whenever there is a uterine rupture, spontaneous rupture in unscarred uterus, and if it is a very bad rupture, one has to take a decision to proceed with the hysterectomy. With infection, so many times there is so much of uterine necrosis that hysterectomy becomes mandatory as a life-saving procedure. So this is just I am adding where the fertility sparing has limited role in obstetrics. After obstetric indications, we come to gynecology, and in gynecology, we can divide it as indications, fertility sparing procedures for benign pathologies and for malignant pathologies. So, to start with benign pathologies, we all know pelvic organ prolapse. There are so many conservative approaches such as ring pessary or uterine conserving surgeries, hystropexy, and all sorts of sling operations. And viewers are requested to visit this or go through this video on pelvic organ prolapse management and overview, which is available at PGOG. There are so many topics where giving details is not possible because this topic itself is so lengthy. And for postgraduates, especially, my request is if you get a question, you have to see whether you get a short answer question or long answer question, and accordingly decide how much detail of each procedure you are going to write in theory paper if you get this in the theory paper. Now, pelvic organ prolapse, AUB, where medical management, LNG, IUS plays very important role. Leiomyoma, where we can proceed with myomectomy, or we can proceed with this high intensity focus ultrasound, which can be done as a um, magnetic resonance directed, MR directed. Now, coming to myomectomy, it is very important fertility sparing procedure which is used for the benign gynec condition, that is leiomyoma. One should remove only symptom producing or fertility hampering fibroids. Excessive resection can hamper fertility. This is one important principle we have to always remember. Not that we see 10 and we remove 10. Not necessary. Those who are likely to be symptom producing, such as those which are near the uterine cavity, or which are fertility hampering, such as a fibroid which is at the uterine cornu, blocking the fallopian tube. Asymptomatic submucous fibroids are to be removed, and this can be removed successfully by hysteroscopy. Myomectomy can be done as open procedure, laparoscopic procedure, and robotic procedure. But the literature shows that base fertility is potential is possible with robotic myomectomy as compared to laparoscopic. So if we see laparoscopy has better future fertility potential because of the less handling of the tissues, and compared to laparoscopy, robotic is even better because of the better suturing which is possible with robotic, so that risk of uterine rupture in subsequent pregnancy is least with robotic myomectomy. One should always do a contained morcellation to avoid spread with a surprise leiomyosarcoma whenever we are doing a laparoscopic or robotic myomectomy. Hysteroscopic myomectomy, if removal of more than one myoma is being done hysteroscopically, then one has to take care to prevent intrauterine adhesion formation in the future by inserting intrauterine balloon at the end of procedure and simultaneously giving high dose estrogen vaginally for 3 weeks. This will prevent development of intrauterine adhesion formation. This MR HIFU or MR HIFU is magnetic resonance high intensity focus ultrasound in leiomyoma. It is a thermoablative technique. It is an alternative to myomectomy. It is possible only when bladder or bowel is not interposed between the uh, fibroid and the machine. And fibroid should be easily accessible and size should be preferably less than 10 centimeter. Contraindications are number of fibroids greater than 4, less vascular fibroid, and whenever fibroid is associated with severe adenomyosis, it is contraindicated. This is an approved technique as a fertility preserving procedure. It has a like a, after post technique, the possibility of successful pregnancy is high. Can we use uterine artery embolization for leoma as a fertility preserving procedure? The answer is big no. UA in leomyoma is not a good option for fertility preservation as compared to myomectomy. Reason is it is associated with increased incidence of miscarriages, placental abnormalities, reduction in live birth rate, reduction in ovarian reserve as compared to myomectomy. UAE for leiomyoma is a treatment modality if fertility is not desired. But remember that UAE is in obstetric hemorrhage has a major role with so many cases where the patients have conceived successfully after the procedure. So in obstetrics, UAE has a uterine artery embolization has a definite role, whereas in leiomyoma, it has no role as a fertility preserving procedure. Myomectomy or this high intensity focus ultrasound is better. Now, other benign pathologies where fertility sparing plays a role is adenomyosis. If it is a diffuse adenomyosis, medical management is preferred by giving usually GnRH antagonist over triple flap method. Triple flap is uterus is closed in 3 layers. Still, in spite of that, there is increased risk of uterine rupture and placenta accreta spectrum whenever surgically diffuse adenomyosis is treated. So subsequent pregnancy, uterine rupture and PAS risk is very high. And that is why for diffuse adenomyosis, medical management is better. For localized adenomyosis, excision can be tried. Whenever there is a hydrosalpinx and patient has infertility, we all know that salpingectomy improves the fertility potential. But in this case, whenever we are doing salpingectomy, dissection should be done close to the tube. We have to preserve medial mesosalpinx and we have to preserve utero-ovarian ligament. We have to use minimum cautery near ovary. All these precautions are taken to preserve ovarian blood supply. Whenever laparoscopically salpingectomy is being done for hydrosalpinx in infertility. Now, whenever there is PCOS, previously, laparoscopic ovarian drilling was used as a modality of treatment, but now it has been completely replaced by medical induction because of the risk of reduction in ovarian reserve with laparoscopic ovarian drilling. Whenever there is a premature ovarian insufficiency which is suspected or there is a strong family history in a woman, then there is a need to proceed with counseling for cryopreservation of oocyte. Once POI sets in, then in that case, cryopreservation of oocyte becomes sometimes difficult. And that is why suspected cases or with a strong family history only, we have to take a decision about the cryopreservation in cases of premature ovarian insufficiency or premature ovarian failure, as we used to call it. Cervical intraepithelial neoplasia, fertility preservation is possible, especially with CIN2, 3 or HSIL. Cold knife conization can be done, but the depth of the cone should be kept less than 10 millimeter if feasible. Complications of this procedure are cervical stenosis as well as incompetence. Next is loop electrosurgical excision procedure, LEAP. Cervical stenosis rate is still high with LEAP. It is 8%, and so periodic cervical dilatations are recommended after cold knife conization or after LEAP to improve the fertility potential. Laser conization can also be tried. LEAP is better as there is lower preterm births with LEAP as compared to conization. Next, when we come to important organ, that is ovary. Whenever there is a benign ovarian enlargement, in pre-pubertal age group, we have to avoid surgery for unilocular thin-walled cyst, and it needs to be observed for 3 to 6 months. And if the cyst is growing in size, then only surgery is recommended, because preservation of ovarian tissue is very important in pre-pubertal age group. If there is ovarian torsion, the treatment is not oophorectomy but detorsion, irrespective of the Doppler showing presence or absence of blood supply to the ovary, because it is seen that after detorsion, even if preoperatively there is a minimum blood supply, there is a regaining of the blood supply and resumption of ovarian function in many cases. So standard treatment for ovarian torsion in modern gynecology now is detorsion, and if necessary, plication of ovarian ligament, that is shortening of the ovarian ligament to prevent future torsion. In benign ovarian cyst, we have to proceed with cystectomy or unilateral oophorectomy. Whenever there is an endometrioma, excision without stripping of the pseudocapsule is very important to preserve ovarian reserve. Or one can proceed with sclerotherapy. What is done in sclerotherapy is USG guided aspiration of the endometrioma is done, followed by injecting sclerosing agent such as ethanol in the cyst cavity. This will preserve the ovarian reserve, but the risk of recurrence of endometrioma is greater with sclerotherapy. Whenever we are treating the endometrioma, cautery should be used as less as possible, minimal use, and sutures are to be used for hemostasis rather than using cautery to preserve the ovarian reserve. Now, these are very small tips, but they go in long way in maintaining the ovarian reserve and fertility potential of a woman. In ovarian cancer, whenever it is a stage 1A, grade 1 or grade 2 ovarian cancer, stage 1A is growth limited to one ovary, capsule is intact, there is no tumor seen on external surface, and ascitic fluid is negative for cancer cells. Along with this stage 1A, grade 1 or 2, if patient wants fertility preservation, we can proceed with unilateral salpingo-oophorectomy with preservation of uterus and contralateral ovary. Other ovary and uterus are to be removed after completion of childbearing at the earliest. Whenever there are borderline ovarian cancers, cystectomy also can be done to preserve the ovary, or unilateral salpingo-oophorectomy can be done. In germ cell tumors, D-germinomas are notorious for being bilateral, where preservation of one ovary with excision of one-sided D-germinoma, whichever is smaller, is tried with the removal of opposite-sided ovary and um, tube. Immature teratomas usually are unilateral. Unilateral oophorectomy and fertility sparing surgical staging is done. Now, in all these cases, surgical staging is done as done in patients for hysterectomy with bilateral salpingo-oophorectomy for suspected ovarian malignancy. Mature teratomas, ovarian cystectomy is sufficient if possible with preservation of ovarian tissue. Now we have to always remember that oocyte cryopreservation is an option which needs to be discussed with patient and which needs to be kept in our mind whenever there is a possibility of drastic reduction in ovarian reserve because of our procedures, or there is a need of bilateral oophorectomy. So this is important uh, to follow in coming years in modern gynecology. Oocyte cryopreservation counseling and procedure. Next important fertility sparing surgery is laparoscopic ovarian transposition. It is simple, safe, effective, and underutilized. It is done before planned pelvic radiotherapy for lymphoma, cervical cancer, anal cancer, or rectal cancer or urinary tract cancer. It spares ovaries from sterilizing dose of radiation. Ovaries are relocated with preservation of original blood supply. Transection of utero-ovarian ligament is done. Utero-ovarian ligament, and if necessary, even proximal tube also is sometimes needs to be transected. This is how the utero-ovarian ligament is transected. Incision is given along the ovary, and then it is positioning is done outside the pelvis in the upper abdomen. These are ovaries are placed high in paracolic gutters outside the pelvis. This can be done as with laparoscopy or robotic surgery, which is preferred as timely radiotherapy can be initiated as compared to open surgery. There is significant preservation of ovarian function, which is found in 50% of the cases after this ovarian transposition. If there is a tubal problem, ovum pickup for ART is possible transabdominally in future. Rare complications are sometimes there is intestinal obstruction and cyst formation in these ovaries. Now, interestingly, uterine transposition has also been mentioned in literature. There are case reports where uterine transposition is done outside the pelvis, and post radiotherapy, uterus is retransplanted with successful pregnancies. Fertility sparing surgery for cervical cancer, stage 1A. For that, stage 1A is diagnosed only by microscopy with depth of invasion less than 5 millimeters. In stage 1A, we have again stage 1A1 where the invasion is less than 3 millimeters. And with that, if there is no lymphovascular space invasion, conization is the fertility sparing surgery. For rest of the stage 1A, that is, whenever there is a lymphovascular space invasion, radical trachelectomy is the treatment of choice, surgery of choice. And for stage 1B1 also radical trachelectomy can be done. Stage 1B1 is invasion greater than or equal to 5 millimeters, but the growth is still limited to cervix, and greatest diameter of the tumor is less than 2 centimeters. So limited to cervix, invasion greater than or equal to 5 millimeters, but greatest diameter less than 2 centimeters. That is stage 1B1, where radical trachelectomy is done as a fertility sparing surgery. This is how conization is done, and this is how this radical trachelectomy is done. It can be done vaginally, abdominally, laparoscopically, or robotically. Indications, as we have already seen, stage 1A1 with lymphovascular space invasion, stage 1A2, and stage 1B1. Structures removed are cervix, parametrium, upper part of vagina, and pelvic lymph nodes. After the procedure, cervical cerclage is always done. Coming to endometrial cancer and endometrial intraepithelial neoplasia, endometrial cancer stage 1A1. Stage 1A1 is where the malignancy is limited to endometrial polyp or to the endometrium, and it is a endometrioid type of tumor, and it is a low grade tumor. These are the cases where we can proceed with progestin therapy as a fertility sparing modality. Success is seen in majority of the cases, that is 75% of the cases, but we need to be cautious because with this endometrial intraepithelial neoplasia, sometimes there is a hidden or undiagnosed endometrial carcinoma in as high as 25% of the cases. And in a small cohort of cases of this carcinoma endometrium, there is no response to progestins. So we need to keep the patient under careful follow-up because of these two reasons. Recurrence is seen in 1 year in almost 25% of the cases after progestin therapy because of these reasons. So periodic transvaginal sonography and endometrial sampling needs to be done every 3 to 6 monthly till there is complete resolution of this EIN and cancer, or we proceed with hysterectomy. EIN was previously known as atypical endometrial hyperplasia. Now, drugs used for this progestin therapy are given for 6 months, such as magestrol acetate 40 to 200 milligram per day. Medroxyprogesterone acetate 10 to 20 milligram per day can be given as a continuous drug form, or cyclically it can be given for 14 days in a cycle. Injection DMPA 150 milligram every 3 months. Micronized progesterone 100 to 200 milligram per day can be given as a continuous regime, or cyclically it can be given for 14 days. And LNG IUS can be used, which will be effective for 5 years, and we can combine GnRH analogs with LNG IUS for better efficacy. What are gonadotoxic treatment modalities? That means modalities which affect ovary in females and testis in males. Chemotherapy drugs, especially alkylating agents and cyclophosphamide, is the most commonly used drug which has maximum gonadotoxic effect. It leads to premature ovarian insufficiency by damaging the growing follicles. It acts on the cohort, and that is how it leads to the reduction in ovarian reserve and premature ovarian insufficiency with development of a premature menopause. Now there are so many newer cancer drugs. As we know, there are immunotherapies, molecular treatment modalities like PARP inhibitors, PARP inhibitors. For all these, there is uncertainty about their long-term effect on gonads because these have just been introduced in clinical practice, and that is why here also there is a possibility of gonadotoxicity, or we cannot rule out the risk of gonadotoxicity. Now, whenever pelvic irradiation or whole body irradiation is given, then there is a risk of gonadotoxicity or damage to the gonads. Now, in these cases, fertility preservation modalities are cryopreservation of oocyte or embryo or sperm or semen or ovarian tissue itself. Indications are gonadotoxic chemotherapy, pelvic or whole body irradiation, or whenever there is a suspected or high risk of premature ovarian insufficiency. Now, this is important. Role of GnRH agonist in whenever in especially in breast malignancy, whenever chemotherapy is being given in young women to protect the ovary or to protect the ovarian reserve or to protect the ovarian follicles during the or throughout the duration of this chemotherapy, GnRH agonists are given, and there is a possible protection, ovarian protection is there, no confirmation is not there, still it is being tried in many cases with a possibility of ovarian protection by GnRH agonist whenever patient is on chemotherapy. We have to delay gonadotoxic chemotherapy for 1 month and do the ovulation induction and do the cryopreservation of mature oocyte or embryo. Now, sometimes this delay is not possible, especially with some of the malignancies where we cannot wait even for 1 month to initiate the chemotherapy or radiotherapy. Secondly, embryo is a shared property with the present partner and there can be problems in future. So in such cases, cryopreservation of ovarian tissue has been uh, documented in literature when because there will be no delay in initiation of chemo or radiotherapy, and this ovarian tissue can be re-implanted after the treatment, or even there are reports of in vitro folliculogenesis in this ovarian tissue. So science is going in or advancing so fast in so many directions. When we read such topics, we feel like that. Cryopreservation of sperms and semen is possible in male cancers. So now we come to the summary of this topic, fertility sparing treatment modalities. Now I was thinking what should be the title. It took me a while to decide about the title. It took me almost 2 to 3 days to decide about what should be included under this topic. Then, when I searched the literature, I found that even obstetrics also have so many modalities which are fertility sparing. And in gynecology, in benign pathology also, there are so many fertility sparing modalities. Though so many times literature is flooded with this fertility sparing treatment modalities only in gynec cancers, but inclusion of these modalities in benign pathologies in gynecology and in obstetrics is mandatory for us. And in obstetrics, there are two, may we can divide it as modalities where there is a possible, we mainly focus on uterine conservation, and second model treatment modalities for fallopian tube conservation. Gynecology we can divide as benign and malignant entities. Now this I call this as a mind map. I have talked about mind map long back when I started with this PGOG in one of the videos, and I don't know whether you have gone through that or not. What is mind map is whenever you read a topic, you yourself draw a diagram like this. In this, you include all the important terminologies. That is one thing. Second is you include all the terminologies or the information which you find difficult to remember, so that each person's mind map will be separate. This is my mind map. This is mine. I have developed it, designed it for myself. Similarly, I request you to have your own mind maps for every topic, so that whenever you, if you have a, say, a register of mind maps, or you have a folder in your laptop of mind maps for various topics, and just one day before examination you go through all those mind maps, it will be a best way of revising the subject. Or even before practical examination, it will be a help for you. So fertility sparing in obstetrics. We will focus on obstetrics in this slide. Uterine conservation, most important. PPH, for which if medical management fails, we go ahead with balloon or compression sutures, vessel ligations, or uterine artery embolization. Even APH also goes hand in hand with PPH with the similar modalities. Vesicular mole is bleeding profusely, you can proceed with uterine balloon or uterine artery embolization to prevent hysterectomy. In non-tubal ectopic, scar pregnancy is very important, Caesarean scar pregnancy, where laparoscopically, vaginally, or hysteroscopically, or by doing uterine artery embolization, you can deal with that, or methotrexate also can be used along with UAE. Cervical pregnancy, first drug of modality of treatment is methotrexate use, and it can also be dealt with along with UAE, cervical pregnancy, or excision can be tried along with methotrexate, or even vasopressin injection. Coming to tubal conservation, whenever it is a tubal ectopic, methotrexate plays important role with or without KCL. KCL whenever there is a fetal heart present. Salpingostomy is the surgical modality which is helping to preserve the tube. Interstitial pregnancy, chemoembolization plays a role where we are injecting methotrexate first and then proceeding with embolization, uterine artery embolization. In cases of abortion, suction evacuation is better than proceeding with a sharp curettage. And for retained products of conception, hysteroscopic removal is better to prevent risk of intrauterine adhesion formation. So these red ones are fertility sparing surgeries in obstetrics, such as giving uterine compression sutures, vessel ligation, stepwise devascularization, and going with a laparoscopic vaginal or hysteroscopic approach to deal the cesarean scar pregnancy, or to do salpingostomy for a tubal ectopic, unruptured tubal ectopic pregnancy. Purple, I have used purple color for UAE because UAE stands out so much in obstetrics as a fertility sparing treatment modality, uterine artery embolization. Now we come to gynec, and in gynec we first will see for the benign pathologies, where for CIN you can go ahead with a cone or lip. Cone can be as a cold knife cone or laser conization. Endometriosis, endometrioma especially, we can proceed with sclerosing therapy or not to strip the pseudo capsule. AUB, all in palm coin, all this palm, polyp, adenomyosis, leiomyoma, and malignancy, there is a place for conservation, uterine conservation possibility. Pelvic organ prolapse, strong possibility of fertility potential sparing surgeries by conservative approach such as ring pessary or various types of uterine conserving surgeries. So ovarian mass is sometimes tricky, and it needs better sensitivity of an operating surgeon to focus on ovarian conservation or on preservation of ovarian reserve. Twisted ovarian tumor, detorsion is the treatment of choice. Benign ovarian mass, cystectomy is done or unilateral salpingotectomy is preferred. Especially for leiomyoma, myomectomy is better, or we can proceed with the this magnetic resonance guided high intensity focus ultrasonography. Remember, uterine artery embolization is not treatment of modality as fertility preservation for leiomyoma. Coming to now malignancy as a fertility sparing procedures. If early stage ovarian cancer, borderline cystectomy can be tried, or unilateral salpingoprectomy can be tried. Carcinoma, endometrium early stage, progestogen therapy can be given. Progestins can be given. Early stage cervical malignancy, conization or trachelectomy plays a role as fertility sparing surgeries. If it is a late stage malignancy and we have to proceed with chemotherapy, then GnRH analogs play a role, agonists play a role for the ovarian protection. For radiotherapy to protect the ovaries, we have a choice of important fertility sparing surgery is ovarian transposition. Whenever we are planning with pelvic irradiation or whole body irradiation. In late stage malignancy, where there is no possibility of gonadal preservation, then we need to discuss and proceed with cryopreservation of either oocyte, sperm, embryo, or ovarian tissue. Now, if we are asked only about fertility sparing surgery in obstetric and gynecology, then you will have to limit your uh, topic to these procedures only, because non-surgical you will not be able to include, because the topic is fertility sparing surgery in obstetrics and gynecology, where in obstetrics you can discuss compression sutures, vessel ligation as stepwise devascularization including internal iliac artery ligation, laparoscopic or hysteroscopic excision of scar ectopic, hysteroscopic or suction evacuation in cervical ectopic, hysteroscopy for retained products of conception, and suction evacuation for all cases of abortion rather than sharp curettage. Fertility preserving for gynecology will be surgical procedures will be myomectomy is very important, conization, trachelectomy, unilateral salpingo-oophorectomy, ovarian cystectomy or detorsion mainly to preserve the ovaries, and ovarian transposition is very important. Non-surgical modalities are in obstetrics. It is very important to remember uterine artery embolization plays a very important role in obstetrics to prevent need for hysterectomy. Methotrexate is mainly for the preservation of fallopian tubes. For various types of ectopic pregnancies, this even methotrexate plays important role for scar pregnancy or cervical pregnancy also. And chemo embolization is where there is a combination of it methotrexate with uterine artery embolization for interstitial pregnancy or even for cervical pregnancy or for a scar pregnancy also. For PPH, we can use balloon, uterine balloon therapy, or we can do for cervical ectopic pregnancy also balloon, uterine balloon or double balloon is Foley's balloon also is effective. Fertility sparing non-surgical modalities in gynecology are for leiomyoma, this magnetic resonance directed high intensity focus ultrasound treatment. For adenomyosis, medical management plays very important role. Similarly, for PPH, very important role, medical management. Progestins for early stage carcinoma endometrium, LNG IUS can be used for early stage carcinoma endometrium as well as for AUB, and cryopreservation is very important non-surgical modality, especially in late stage malignancies or premature ovarian insufficiency possibility. These are the references. The first is a gynecological surgery for benign disease preserving reproductive potential, which has been recommended by FIGO committee in as latest as September 2025, and this is the reference link. Those who are interested can go through the article. Then FIGO best practice advice on fertility preservation for cancer patients has been given in 2025, which also both of these two articles help me a lot to understand the topic along with textbooks of Teeland, Novak and Williams. Thank you so much. The topic has taught me, and that is why this is the take home message for all of us, including myself. Keep yourself updated. Exciting updates await you. Thank you once again.